So pimping stands for put in my place.
If I had my choice of docs in a scenario that was a crapshoot, I'd pick you.
I prefer to make as little decisions as possible.
What do you think AI is going to do for healthcare?
There's something that clues you in where experienced nursing staff, providers, you can look at someone and be like, something's wrong. I don't know what it is, but this guy's going to die.
St. Ignatius.
Sounds like a really base dude. The theme of tonight's podcast is that we are human and we are prone to human flaws. And part of that is we are doomed to make the same mistakes over and over again because we're human.
It's Dr. Kewl, man. What's happening?
Oh, not much.
Right.
Thanks for having me over.
Yeah, man. Glad to have you. We're welcome to Vitals and Virtues, buddy, in my nice little cozy basement. We're drinking a little scotch, and we're going to talk about lots of stuff, or as much as time permits. But Dr. Kewl, most of the people that know you, I think that I've had to go with something that would be pretty fitting, because every doctor I know, when they're like, I need if I wanted technical skills, not to say that your clinical practice is subpar, but your technical skills, everybody is a little jealous and envious. And I could like walk you down a list of all the docs that we work with. I mean, it's something. It's just.
You're too kind.
I mean, look, we gotta build you up. You know,
right.
We'll break you down later, maybe. But yeah, how's your shift today, man?
It was okay. It was not bad, really. I can't complain. It was easy.
So the difference between we just tried some Macallan 12 and now the Ardbeg. There's such a difference in the taste there. One is like smooth and cozy. The other one's like, well, that cozy fire just erupted into your living room. Now you have to eat it.
It's like drinking campfire.
Like kind of, yeah. It's not bad. It's good. Like I like it, but
I actually really like that PD.
Keep that. You gotta get that mic closer.
Oh, okay.
Nick, pull it till you get comfy, man. You look like you're stressed out. Like this isn't a lecture. Speaking of lectures, though, lectures. Let's get into who you are without getting into who you are. How long you been a doctor?
I have been, so I'm 7 years out of residency, so I guess 10 years after med school.
Dang.
Yeah, I'm old.
So been a doc for 7 years practicing independently. What? Because I think about things from the nursing perspective, and in the role that I'm in now, I get to interact with the physicians a little bit more than not. It's a very different way. Like I feel less. It sounds weird, but like less like a subordinate and more like a collaborator. And it's essentially just because I have access to different resources in my current position where do we need to sort out transportation? What is it that needs to happen, and who do I need to call to make that happen? And you had sent me a podcast to listen to. What was it called again?
The Day I Didn't Use Ultrasound.
So I didn't actually get to the point where he said that.
It's kind of an inside joke because the guy, Mike Mullen, he is an ultrasound fellowship trained doctor. So all of his prior stuff that he gives lectures on is about ultrasound.
Okay.
So this is his non-ultrasound lecture, I guess.
Gotcha.
Yeah.
It was a really nice lecture. Could you give like a little bit of background about that? Because I think it's going to play in a little bit to what I wanted to talk to you about.
Yeah, so for me, it was a really impactful lecture and podcast. I would recommend, if anybody has not heard it before, to go ahead and look up The Day I Didn't Use Ultrasound.
I'll put it in the description, so if anybody wants to tag that. I thoroughly enjoyed it as a nurse. Like a lot of the principles that he tossed out were discussed super applicable for so many different, areas of, whether it's practice or even home life. Like,
Yeah, and spoiler alert, it's a airway case, and it's a disaster airway case, and but it's really not about the medical parts of it, but the human factors and decision making. So for me, it opened up kind of a interest in what they call metacognition. So it's going to be thinking about the way you think. And I think specifically in emergency medicine, there's a high proportion of people who are interested in that,
Yeah.
as opposed to other specialties about like decision making, crisis management, stress inoculation. So a few different factors, like human factors.
When he was saying stress inoculation, I was just thinking like this seems like just immersion therapy. Like you just have to get stuck in a terrible situation. Like I'm sure there are better ways to do it, but I just kept thinking of like Marine Corps boot camp, like stressed out constantly. I don't remember not being stressed for 3 months. But over time, like it is an example of how over time you stop being so like afraid of, like drill instructors are scary dudes, especially if you're a little guy like me. Like I'm 5'6". I was 5'7" when I went in. Maybe their tape measure was wrong. Maybe I've always actually been 5'6". But anyways, I'm a small guy, and all of the drill instructors that we had were like over 6 foot tall and just built dudes, and not like they're just big dudes, and they're strong and they're scary and they scream at you a lot. So for the first month and a half to 2 months, like you're afraid these people are going to murder you because they tell you they probably will any given night, and they just prowl like sharks constantly. But after a while, I think it was like right around a month and a half. And there's always changes. Like you go to a different barracks, you do different things. You're doing different either education pieces or physical, fitness stuff or rifle range. Like there's always changes that are happening. But at some point, there's always the baseline of you getting smoked, like constant PT, any downtime. If anybody even sneezes wrong or blinks, you're going to have to do push-ups or burpees or some dumb exercise for a long time. But at like halfway through, you start to be like, all right, this is just the same thing every day. Like it's fine. And a week before our last training, like before we got out, or maybe 2 weeks, we had done, it was called final drill. Like the Marine Corps is big in drilling. Like if you can't follow orders very specifically to detail and pay attention, what does that mean on a battlefield? It means you're going to hesitate when the time comes. So you need to follow orders right then and there, exactly as ordered. So drill is one of the ways that they condition you to do this well. And while we had done during final drill, the senior drill instructor, he actually owned up to this afterwards, that it was his fault. He didn't call cadence on the exact time for us to turn a certain way, to be marching with the right foot on the line as we're on the parade deck, which this might sound like a bunch of nonsense to anybody who's not in. So anyways, we get taken back to the squad bay, our barracks, by the 3 other drill instructors. Our senior drill instructor stayed and watched the rest of these people doing their drill, the different companies, different platoons within our company. And when we get there, like all the other drill instructors decide that they're going to just haze the heck out of us. So we're in there, and it seemed like forever, and we just kind of got, like we honestly got bored of just sitting. Like there's only so many people that are allowed to get hazed or smoked on the quarterdeck, as they called it, at a time. Me and my buddies were like, let's just go up there. But so essentially, this is a long way of saying it took us like 10 weeks or 11 weeks or something before the whole like stress of all of this crazy environment was like just every day, like, let's just go get smoked on the quarterdeck because we don't care anymore. Like, what are they going to do to us anyways? Various like stages where that's, varying levels of stress. But the whole inoculation piece, like that spoke to me. There's a long shtick about like an experience I had where I was able to like really identify like that does work in that environment. So it's got to work elsewhere, and probably with much less weeks of screaming and drill.
Well, you actually brought up something really important, is that you mentioned fear a few times there. Mm-hmm. And all right, I have no military experience, so I can't really relate to it. But so in medicine, so like in your rotations and residency, there's a lot of like pimping type of things. Have you heard
he
of that
mentioned
term,
this, and I'm like, what is he talking
What's pimping?
about?
So pimping stands for put in my place.
Ah.
It is where a senior person asks a question to like a junior person and expects them to give an answer. But sometimes it's arbitrary stuff, and sometimes it's like it's just a way of like exerting authority. So like there's more benign pimping that might be like, what's your differential chest pain? But then there's like some more like really obscure stuff that people might pimp you on. So when they say pimping, that's what they refer to.
Yeah, so I was really confused by that. I was like, this has got to be a medical term. I'll have to ask Zane about.
It's an extremely medical term.
Yeah.
But fear is a critical component to this. And actually, when we're talking about human factors, fear is... It's important to understand emotions, and emotions have an extremely strong correlation with memory. So like that story that you told had so much detail, because anytime you have an invoked emotion, and usually it's fear, you never forget that. So that like hardwires it to your memory, and that's an evolutionary trait. So like if you were a caveman and you, let's say, go on thin ice and fall into the ice, and you are terrified and you think you're going to die. Or maybe it's a relative and they do die, and that's like your relative that you are now mourning. The fear of that gives you a extreme response to thin ice from there on out. So it's like a way to create a very strong memory. So actually, I would guess that a lot of they may not have thought of it as this, but like when you were in boot camp, they were trying to hardwire you with certain instinctive responses.
Yeah.
And they do it by creating fear. And a lot of medical training is like that, where they create like a very embarrassing thing where you're made to look like an idiot in front of your peers. But they do it because it forces you to remember so clearly and vividly.
Well, it was funny. So I had actually taken this approach when I would precept new nurses, and I didn't do it very openly. I had to do this on the side, and not because like I wanted to be a jerk to anybody, but I remember thinking when I was precepting the first few people, and some of them were students, and like it's a weird balance in nursing because I think the investment isn't as high is what it is for the medical practice. So the whole idea of pimping in, if you're a med student and you've already been in for a couple of years, like you are very financially invested, emotionally invested. You're probably not going to be like, this guy made fun of me, I'm going to back out now. Like, but in nursing programs, like,
does it happen?
I'm sure it does, but I didn't want to be the cause for it because it's not like the emotional and financial investment is nowhere near as high. So, I didn't make it because I didn't want to deal with this guy and his meanness. But anyways, I started like I remember all these things from boot camp because I was humiliated doing them. So if I had gotten to a point where I had told a new student like 3 times or more, like, this is how you do this, or this is the thing that you're supposed to be doing at this point, and they just not picking it up, I would just try to, like, sounds so mean, but like belittle them and make them feel very embarrassed and like stupid essentially, because I knew that they would remember it the next time, and like it worked.
I bet you
it
did.
Worked so well.
I was going to say, I bet you they remembered it.
Like I did feel bad, but I mean it's also different because it's like sometimes like I'm a dude just being mean to these like young ladies, and it's like, and some of them like they had come back to nursing like later on in life, so they were some of them were almost twice my age, and I'm like, how many times we got to do this, Grandma? And they told me this like 2 years later. They're like, yeah, I still remember how to do that thing because somebody had to say like, how many times are you going to do this, Grandma? And I'm like, dang it. It's just little things. What's funny about this is on the flip side of it, fear is a great tool for remembering. I can still tell you who two Marines, 2 medals. Dan Daly and Smedley Butler were 2 Marines who got the Medal of Honor. That was a ditty they made us scream in 2011 when I was in Paris Island. So this is 14 years later. I can still remember this dumb thing that we had to scream, and a whole bunch of other ones. So in fear is a great tool for retaining information. But I could also tell you all of these dumb quotes from stupid movies where I was absolutely not afraid of, watching Tommy Boy or SpongeBob, but I could also quote them really well.
Well, a lot of emotion is so. Like in general, human emotion is like very strongly tied to memory, and fear does tend to be probably one of the more powerful ones. But actually, like something funny or something that you had a really good time or a positive experience would also be part of it. Actually, so there's a couple books that they had mentioned in the podcast, and one of them was Deep Survival, and that one talks a lot about emotions, and it's a very interesting book about a lot of case studies where these are pretty much all disasters, where people do inexplicably stupid things, and in retrospect you're like, why would they do it? But then if you analyze it, the explanation is some sort of emotional mismatch, and it's not always fear. So one of the first examples he gives is there was a team of snow rescue people. So they would go out in like avalanches and rescue people. And there was a day where there was it was like peak avalanche conditions, and they were warned not to go out and it would be highly dangerous. And a whole bunch of them, like 10 or 12 of them, went out despite the warnings, and they were all expert professionals. And they kind of went for this joyride that ended in disaster, and like the majority of them died.
Pride comes before the fall.
Well,
right?
It's because they have a strong emotional attachment or understanding of how fun it is to zoom across the snow, and they did not have a memory of how terrible it is to be buried by snow. And so the logic gets completely overshadowed by the emotion, what they remember, if that makes sense. So like another example, like a more kind of extreme example, but there have been a lot of people who go diving, and when they feel panic, they remove their helmets and drown. And the reason why is because when on land, if they felt claustrophobic, they would try to get everything off their face to try to breathe. So even though their brain could tell them, logically, you could sit them down and say, hey, what will happen if you go down deep and take off your helmet? They'll say, I'll drown. But at that moment, the emotional desire to feel free and to rip off their helmet superseded their logical faculties.
Yeah, I mean, the other piece that guy talked about in MCRIT was the different levels of like where you want to be in like stressful situations. Like essentially, I mean, you're the doctor here. Help me out. But the different levels of stress that you function very well in, and then some that you are like, no, that your brain stops working.
Yes. So that was another really good part of it. So it's going to be more the physiological effects of stress. And so the best way to think about it from like a medical professional is that while, let's say it's something, it's not just a code, it's like a pregnant code or a child, something like truly
it's not an expected 80-year-old that's coding.
Exactly.
This is like somebody your age,
yes,
that otherwise appears healthy.
Or an airway disaster, like somebody who you go in thinking that this is going to be an easy tube and it doesn't, and you realize. So stress, the definition of stress is when you perceive your challenge to be greater than your capacity. So that could be if I can only see 20 patients a shift, and then you get loaded with 30, Or if it's you can only see 10 and get loaded with 15, same thing. So if you are in a stressful situation like that, your body is being flooded with pressors. You're on norepi. You're on epi. You're probably on like stress steroids too. So think of it like all that cortisol. So
Yeah.
you're going to have a physiologic response to that, and that also affects your brain too. So they mentioned a few different levels, which I should probably bring up. It was white, yellow, orange, red, and black. Where white is like completely complacent to the point that you're asleep. And they had a few vital sign changes associated with that, which is a ballpark. But everyone's going to be different, of course. And yellow being like a very alert but calm. Orange being like the next level above that. That's going to be a little bit more stressful, but you're in control. And then red being you're starting to lose a lot of, I think,
So
cognitive awareness.
Okay. Where do you lose your like fine motor skills? Was this in?
You'll start. I think that's orange actually. So like once you get to orange, or certainly by red, you're losing it. So in those kind of situations, you fine motor is going to go away. So you're really trying to stick with gross motor.
Yeah. So like your fine motor skills start to go when you're at like orange, or not necessarily go, but you can tell like you might have a tremor.
Yes.
Or something like that.
Like that guide wire starts flopping.
Yeah, or you're trying to put in an art line or a central line or something. Like things just are not going as smooth, and you're not hitting the things that you would hit if you're totally calm.
Exactly. And then once you get to red, you're really losing a lot of fine motor, and you're basically you're down to gross motor only. And once you get into the black, I mean, you're talking about legitimately loss of bladder and bowel.
Or consciousness, I suppose, depending on your.
And I have seen people go to the black in the medical setting. I don't know if you have or seen it in the military setting, but I've seen people. A lot of times they freeze is what they're, and they're not actually like pooping themselves, but they are legitimately frozen, and they cannot proceed because fight, flight, and freeze, and actually freeze is a more common one.
Yeah, when he mentioned those, I was like, yeah, freeze is where so many people find themselves. Now, I haven't. I mean, it's fortunate that I had worked with really like top-notch folks who generally don't. I think maybe in some sense it's more of like maybe people have enough self-awareness where they recognize like, oh, I need to go find myself some other task to do right now and get out of this room because I'm not fit for it. I did once, one of the docs when he was putting in a central line through the groin, and I was like, I feel funny. And I like sat down, and one of the nurses was like, nope, get out. You're getting out. Like, we're not doing this. And like everybody has kind of like a thing that sort of makes them queasy. And that's kind of what I would call that. But what's like the worst scenario that you've been in where you would say, I got close to like red or black? I mean, you're Dr. Cool. Like you don't get to red, but you got to have something.
So it was my crike. The funny thing is, so my crike was in residency. It was actually quite similar to the podcast episode. So we were all in level white. We were overnight. It was 6:40. We were off in 20 minutes.
Oh, man.
Somebody came in with some shortness of breath. And then we decided to be nice and see it just to kind of get them started. But it was a angioedema. And this guy, he was young. He was like 40. And he looked okay. But we decided to scope him, do an NP scope. These angioedemas, so a lot of them, a lot of the crikes I've seen have to do with cocaine, and somehow there's some cocaine involved, and they all kind of go like the same way where they can crump really fast, and this guy did. There were a few factors that led to that, which I won't get into details of, but the short version is this dude dropped his sats from like 100 to like 10, and that's the other weird thing is they'll have a good pleth. They'll have a good waveform, and you can legitimately see their sats just drop and drop like a rock. And so my attending went to intubate. There was no view, and it was truthfully, it was a paramedic that saved us. And the paramedic, because I just sat there and I was just staring. I didn't really know what to do. And the paramedic,
This is why paramedics are better than nurses, according to Chris Andrews. Sorry, continue.
so the paramedic handed me a chloroprep and a blade and just handed it to me. And then
Solid.
I just prepped his neck and I started cutting. And most crikes, I actually did a M&M on this, so I did a little bit of research on recent crikes.
All right, look, man,
So-
I'm just a lowly nurse. What's an M&M?
Oh, it's a morbidity and mortality. So it's like it's one of those conferences where you look back on either bad outcomes or complications, and you do a retrospective type of examination of what went wrong or what could have prevented it, and that kind of thing. So the crike, based on the nursing notes, was 11 seconds, and most crikes were also in about the 10-second range. Like what they need to go fast, like really fast.
It's impressive that the nurse had kept that detailed a note.
Yeah, it's odd.
Oh,
I mean, I guess there was. I guess there was.
I'm guessing this was a teaching hospital.
This was
so
a
it's
tertiary
likely.
care center where they were very used to scribing. Like, I mean, it was a peri arrest, right? Like,
Did
this
they
was-
also have a recording? Like, because I know some facilities have cameras in the rooms to record like situations like this.
They did have them. I don't think it was on.
Either way, the fact that somebody was able to document the 11 seconds is pretty impressive. And as a resident, you were able to knock it out 1 second past the.
It was one of those times where like things just happened. It just happened. I didn't even know I was doing it. Like genuinely, I did not know it was happening until afterwards.
Was this the first crike you've ever done?
Yes, it's the only
The only crike.
I've ever done.
So, had you done it on like a sim lab or?
I've done it in the sim. Yeah.
Okay. Because I would have guessed like that's something that you would at least have to sim, because it's not like people are getting criked every day. Like it's a rare thing.
It is a rare thing.
Unless you're watching the movie Anaconda.
I never watched that.
Maybe you should. Maybe get some tips.
A crike is like a officer shooting. All police officers probably think about it, train on it a lot, but very rarely does it
Yeah.
happen. So it's something that like we would go over in conference all the time. But like in this situation, it just happened and I didn't even know it was happening. And afterwards, like immediately after, like, the next 2 minutes, I was shaking so much because of the amount of adrenaline that I couldn't talk. I couldn't
Have you ever
do anything. I couldn't tape it down.
Do you hunt at all?
No.
So this is an interesting thing because I don't know if this is a universal experience, but I get this way after I shoot a deer.
It's it's like that pent up anticipation or something to, I'll still like to a much lesser effect after a difficult airway, after it's done, or like a difficult central line.
Yeah.
After it's done,
We just
then
have
you get a
this
little bit of just
dump of endorphins.
It's a
that
dump, yes.
Yeah, you're like, whoa.
It's not like you're nervous anymore. You feel good.
Yeah.
Although, side note, on talking about human factors and stuff, it's always it's always immediately after a successful event, like you just get an airway or you just get somebody back, everyone's high-fiving. That's the risk. And in the military, in these books, they talk about it's the counterattack. So immediately afterwards, that's when you have to be on your toes. So it's, in for example, in this guy, we cracked him, got the airway in, bagged him up. He's 100%. We're all high-fiving. And then he starts pouring blood out and starts coughing up he starts mucus plugging or something. It was the immediate post success that you have to be wary.
Yeah.
That's when balls are dropped.
That makes sense. So, I mean, talking about all this stuff, where's the there's so many things I want to get to. And I'm trying my darndest to not be as tangential as I normally
We're a
am.
bit scattered here. I had like this outline in my mind, and yeah, we're a bit scattered. I'm sorry.
No, it's totally fine. Honestly, this seems more following a theme than I normally do. So, what do you do with the information? So you have these. All right. So we've essentially laid it out in scenarios that go from like everything's chill to holy crap, this person's about to die in whatever like setting you're in. You know, we happen to spend a majority of our lives in the ER. What do you do, or how do you prep for those oh crap moments now? Like, say this were to happen at work at your next shift. Like, what is your process?
So the biggest takeaway, and I know that you always ask what virtues.
Yeah, I
you
try
would have.
to get that.
So I think the biggest takeaway is the virtue that you want to have is know thyself. Like, be aware of your own cognitive pitfalls and your physiological pitfalls, and know that, like, so for example, know that after a case like that, you're going to be spent. Like, you should not try to make difficult decisions. You should realize that you're at risk of error at that point.
Mm-hmm.
You should realize that I should not perform fine motor skills. It's
Don't try to like. This is why scrubs are all. You know, there's no zippers on scrubs. You'd hate to try to do fine motor activities at that point. You end up like, you know,
pensions open.
Code blue in a bathroom.
That's
you know,
right.
like. Anyways, all right, that's enough. But all right, so that's like the what you don't do afterwards. This is pretty cool because there's two saints that I'm like. Today is the feast day of Saint Benedict, who's like the father of Western monasticism. Established like there's the rule of Saint Benedict. There's like plenty of books about the Benedict option that people have. Like, you know, you just kind of have set up rules, which I think is really actually helpful in scenarios like this where, say, you know, your triage nurse says, hey, this is coming in, or you're fortunate enough to get a good report from a squad saying, hey, we got this disaster coming in. Like, this guy's sats are in the 70s and declining. His blood pressure is getting worse. So what is it that you do in that moment where you're like, all right, these are the things that we need to do, what I need to do, like mentally and like maybe emotionally before this shows up, so that I'm the best possible version of me walking into that room? Because you as the physician, like, I've heard a couple docs refer to this as essentially something that kind of gets drilled into you throughout residency is, it doesn't matter if you're about to crap your pants, you need to look like the most confident person in that room. So
That's
what
true.
is it that you do? Like, I'm pushing a little bit on this because you are the doc that, like, if I had my choice of docs in a scenario that was a crapshoot, I'd pick you. Like,
Wow.
You'd be in my top two, top
That's-
three.
That's actually really kind of you. I don't know if I'd pick me. But.
No, you wouldn't. You don't want to deal with the paperwork.
So, actually, this is a whole different field, actually, than what we've been talking about. So, mentally, for me, so there's a whole another subset of what's called team dynamics, and that's
Yeah.
actually a core part. So, the short version, for example, like airway is a really good example. Airway is a really good example for all of this because, like, a surgical airway is something that people have a hard time pulling the trigger on. It's actually not a difficult procedure most of the time, unless there's some anatomical things. But in any case, it's so trauma and airway is a really good example to kind of frame this stuff. So, first of all, the answer to your question is, I do rely on my team. I rely on my team a lot,
Yeah.
especially on my nurses. So you assign roles, first of all, so that way everyone has the same. It's called shared mental model. So successful teams have a shared mental model, and mental model is another thing that they talk about deep survival. This is something where your perception of your world is based on your mental model, and all models are wrong to some extent. But how close you are to reality dictates your success. Like, for example, if you guys have a mental model that somebody's coming in and they're hypotensive and they're bleeding, your mind goes down a totally different pathway than if they end up having a fever and they're not bleeding. So like the mental model and the ability to pivot quickly with when information presents itself that show you that your mental model is not matching with reality dictates your success. And that's a huge part of what they talk about in the book. But not only that, but it needs to be a shared mental model, as in, let's say you're my lead nurse in a resuscitation, and somebody else is the scribe. Somebody else is on meds. So if you all have different roles that are clearly defined and clear expectations, and if I can pre-brief people by saying, listen, we have a code coming in. It's a young person, suspected overdose. I want to make sure we get Narcan. The priority is to have good IV access and then Narcan. Respiratory, I want you to bag, but we're not going to do the airway unless, if it's a cardiac arrest, let's bag them, but let me know if you have a hard time bagging them, then we might force our hand and we have to do airway. So everybody's on the same steps. And actually, when I have a perceived possible difficult intubation, I actually empower a nurse, usually the scribe, because they are sitting back and away from it. I say, if you think that we need to proceed to a surgical airway, I'm empowering you to let me know. Because you can, another thing that we talked about, the book on combat. So in addition to the physiological changes that we talked about with the red, yellow, black, is there are a lot of changes to your perception. Your perception of time changes. Things actually can shift both faster and slower. And they have a lot of officer-related shootings that they have accounts of. And there's like auditory exclusion where you just don't hear. Like there's officers that discharge a firearm and they keep on firing thinking that it's not going off because they cannot hear it. They cannot hear the firearm discharging.
Dang.
There's a lot of like...
It's like you hear about tunnel vision, but like tunnel auditory that is wild.
Changes in your depth. And so that's like airways are such a good example for this because like when you go in for an airway and you just... have you seen the airway where they just keep trying over and over and over? And you as a nurse standing there is probably being like, hey, the stats are dropping. Hey, we got to do something. Hey, we got to like try something different.
Yeah. And they're like, hey, we need a bag. We're
we got to bag them up or something. But they're just so dialed in on the airway that they cannot see anything else. So to have the insight into yourself and realize, hey, I could get in there. So I would empower a nurse and say, listen, if you think we need to proceed to surgical airway, I'm empowering you to let me know.
Yeah.
And side note, I'm sorry, I might be a little tangential.
No, you're good. You're good.
It is my personal pet peeve, the saying that if you do something over and over, the definition of insanity is doing the same thing over and over again. That's my personal pet peeve. Because to do the same thing over and over again is human. It is actually the natural human response to try the same thing over and over again in that situation. Like, have you seen the people who are trying to intubate and they just keep on trying to intubate the same way over? Let me just try it. Let me try again. It is emotionally, like they know the feeling of how good it feels, the relief of sinking in that tube. And that's all that they can feel.
And this is the closest thing I think nurses have with that, or maybe a very close parallel, is when you're trying to get IVs, where nurses will try like, I knew a nurse who would try like 7 times, and I'm like, what are you doing? Yeah. And there's a reason why, like, hey, if you can't get it in 2 attempts, like the mental game, if you have said, I can't get this, I'm not going to get this, and if you miss twice, chances are you're not going to get it on the 3rd try. That mental model of like, or the mental barrier that you have just placed in your head, and it, like, some days are just bad. Like, there's a reason I've gotten good with the ultrasound, because I didn't ever want to have that again. Like, and people joke and tease me that, like, oh, I need the ultrasound at this point.
I know that's not true. I've seen you stick.
Well, somebody the other day was like, oh, you don't have your ultrasound. You don't have your machine. Are you going to get it? I was like, pressure's on. And it was like, people that I respect and I kind of value their opinion, like, heck, one of them's been on the show. Yeah, Chris is getting another shout out. But he was teasing me hard, like, but yeah, like that's the closest I can off the top of my head to say this is a very, very similar situation where you keep doing the same dumb thing. Well, it's not dumb, but it's the same thing, and it very often helps with the team approach to be like, hey, nope, it's time for you to tag out to somebody else. It's similar with like compressions, where people, where some people I know who have been on the chest when ROSC is achieved. Like they were the ones that were on the chest last. So in their head, I don't have anything other than anecdotal evidence on this, but if you have been on the chest and been the one doing compressions at the last pulse check when you get ROSC, you want to be on that chest next time because you think that you're the one that's going to like get them back. But in reality, it's that team approach that's getting them back. It's, good CPR, like BLS, is better than great ALS most of the time. But you should just cut me off because,
No,
pulling a Michael
you're
Scott
doing
here.
good. No, keep coming.
But, I just run out of steam, But where were we? You had another book in your hand. What do we got now?
Well, I do want to also mention, because we're talking emotions, so another core cognitive psychology idea or theory is so this is Thinking Fast and Slow by Kahneman, and I think he's a Nobel Prize winner about this.
Ooh.
So this is a core
Dude,
part.
did you bring all of these books for me to read? For me to borrow at least at a minimum?
If you want them, yeah.
Dude, you
borrow
brought like 6 books. This will take me forever. I'm a slow reader.
You can pick and choose whatever you want to do.
Yeah, I'm sorry.
So this is it's a good concept. It's a kind of a long book to explain it, but basically, have you ever heard of System 1 and System 2 thinking?
I have, but I don't know it well enough to articulate it in any kind of...
I phrase all of my perceptions, my mental model, so to speak, in System 1 and System 2. So the short version is, System 1 is fast, it is pattern recognition, what they call heuristics, and it is a bit error-prone, but it is your gut reaction.
Mm-hmm.
System 2 is slow, it is cognitively taxing, it is more logical based. Instead of jumping to conclusion, it's more like methodical, and it is a little less error prone.
I think of like speed chess versus a slow game of chess.
Maybe actually, might be actually, yeah, actually that might be. So like the short version would be, so if you it's think of it as pattern recognition is System 1. So have you ever, as a nurse, been in a room where you see a patient and the second you see him, you're like, this guy's going to die?
Oh, it's the AVPU, like what you see across the room. Like that is something that you do train on. Like, what does this person look like? Are they gray? Are they blue? Are they red? Like, and it's funny that like as I say that out loud, it's like, why are we naming colors for a patient? But like if you are a healthcare provider, you do look at patients and say, they look like trash. We need to do something yesterday.
But sometimes they don't. You can't put a finger on it.
Yeah.
They're not gray. Their vitals are okay. It's something about the way they're looking off or what they say.
Mm-hmm.
And there's something that clues you in where experienced nursing staff, providers, you can look at someone and be like, something's wrong. I don't know what it is, but this guy's going to die. Yeah. And that's System 1, for example. System 1 also it can fool you. I mean, that's like all the optical illusions where your mind's jumping to conclusions and they end up being wrong. And System 2 is more methodical, and you would think maybe that's better. But the problem is that you can't apply it to everybody because it's too mentally taxing. There's a decision-making pool. It's like concentration, decision-making, some sort of mental energy that is finite, that in that day, this is all you have, and you cannot actually expend it all on every single patient.
As you're saying this is so true for so many things, like just dealing with your children. Like, knowing this, like, there are some things that I need to give, like, all my attention to. Other things, no, I can't.
Yeah.
Like, you two are fighting in this instance, like, my two older children. I'm not going to devote my energy to this because it doesn't appear as critical as like, hey, this is a you problem. This is a Jude problem. He can handle this. And no, if this is a mama or dada problem that we have to get involved, like, yeah, there's so many things that are either so taxing or so not taxing. Oh, that hits.
So case study. They looked at judges in Israel, and the further along in a day it was of court, the less likely they were to offer parole. Because they had made it's a risky to offer parole has some risk. It's a risky decision. This requires mental energy, and they're tapped out for the day because this has been going on so long. Same with antibiotics. Primary care doctors were more likely to prescribe antibiotics for viruses at the end of their shift than the beginning because you don't have the mental you unconsciously don't realize that you don't have the capacity for it, and you're just going to go with the less risky option.
It's essentially the canine unit for law enforcement. The nose only has 30 minutes where it can actually detect stuff. Yeah.
I did not know that.
Yeah. They've got 30 minutes. This is why, like, if you were ever in a high school when they did maybe you went to a better high school than me, but if they had the dogs in, they had like multiple dogs to go through because after 30 minutes, it's like
tapped out.
Yeah, it's tapped out. Like there's only so much, the olfactory shuts down after 30 minutes. What a perfect name for I don't know. Is this an organ? I guess I don't know. It's a factory, it's got to at least be an organ. You're the doctor. Correct me on my show.
Jeez, I can't remember.
But yeah, that is super interesting. That so as a provider, this is why you'd prefer that.
I prefer to make as little decisions as possible. I prefer to save all my decision making for later. So like anytime, the way that it was like when I learned about it, it was taught to me was that if a nurse came to me and was like, "Hey, do you want to give like pain meds for a patient?" And you're like, "Oh yeah, sure." And they're like, "What do you want to give?" And you'd be like, "What do you want to give?" And just like put it back to them, which is probably annoying for you guys.
It's so annoying.
But it is. It was actually taught to us that any decision that you can defer or use as little brain power as possible, you save your. Brain power is the wrong word. It is concentration, and there's a few things that tap into that. One is like exercise, like endurance sports. So I won't run before shift because that taps into the same willpower as your decision making.
Wow.
Another side study that they had done. So they had offered snacks to people after they made them do a bunch of questionnaires. If it was an easy fluff questionnaire, they were more likely to choose the healthy snacks. And if it was like complex math questions and stuff, they would more likely choose like sugary or unhealthy snacks.
What the
It's
heck?
willpower. It's the same. Like I need to think of a better name for it, but it's willpower / concentration / endurance.
Like almost mental capacity. Which
Yes.
sounds like we refer to use that differently. Like when you're almost like referring to patients with MR or something. But it's essentially it is a mental capacity. Like how much can your brain endure throughout whatever the
It's endurance.
thing that needs
It's
to
brain
endure.
endurance.
Yeah.
And sleep resets it.
So this is why, like, what about like with residency, where it's like, oh well, maybe it's changed. I mean, it may have changed since you went through, but you would hear these stories about like either these trauma surgeons or I feel like it's more prevalent with surgeons, but any resident is like you're sleep deprived like crazy, and you're stressed out all the time. Like, is that?
I
like
pulled
what
28-hour shifts in certain ICUs. You come in the morning, you work all the way till the next morning, then round with all of them, and then after you're done rounding, you go home for these 28-hour shifts.
No wonder you decided to not be in an ICU.
But the short answer is it was not designed with this kind of human factors in mind. You lose the capacity.
That water is for you, by the way.
Appreciate it. You lose that decision-making capacity. You are not as good as you were at the beginning of your shift.
Well, it makes sense. I think it's interesting that this stuff. I mean, it doesn't seem like it's only coming out now, but maybe like we give the body way more
Credit.
rest, I think, than we do the mind.
Yes.
Because would you prefer to have a code at the beginning or the end of your shift?
Oh, at the end, for sure. 100%. Because after a code, that's hard to bounce back from. And that's another part, is that you just have to be cognitively aware of it. When I'm single coverage, if I have a code at the beginning of shift, if I have a code at the beginning of my shift and it's single coverage, I mean, I just got to see everybody who comes in the door after that. If I have another code afterwards, well, that sucks, but I just got to do it. But at least I have to be aware that I am compromised.
Yeah. Self-awareness is huge. This is so it's similar to like the rule of Saint Benedict. This is kind of what I've set for myself, because I do know that I get very taxed very easy, especially with like disgruntled family members or visitors, or like it's even worse if it's like a staff member that I have to deal with, because I know that will escalate further, because it's somebody that I have to report to their superior. They're going to likely report to their superior as well and have their story that, I don't see the whole picture. So like, I would say like internal problems stress me out more.
Emotional conflicts also tap in the same thing.
Yeah.
It's tapping from the same emotional or mental resource.
Yeah. So, because I would much rather, like, a code is way less stressful to me in my current role, because like as a supervisor, I don't have to do the charting. Like I do some, like I will do the papers chart, and that counts. So the nurses don't have to do that. Like if it was your patient, you don't have to. If I have to do de-escalation, where there's a patient that's like trying to fight people, I would almost rather do the code, because at this point the variables are fewer. That person's already dead.
Yep.
Like, this sounds bad if you're non-medical. Most people who are medical understand that 85% of codes result in death.
Yeah, and they were already dead.
Exactly. It actually resulted in death already. We just undid it. Yeah. But so then there's so many more variables with families. So recently I worked a situation where there was a lot of family members who were all intoxicated, all trying to visit family. And I'm like, hold the phone. There ended up being like fights in places. It was not good. It was very stressful. I would rather deal with codes than that, because like I said, I know the worst case scenario, they die again. Yeah. And they're done. And I started taking, people are going to be tired of hearing me say this, but I started a bioethics class, because my wife was like, you didn't take a bioethics class before? I was like, no, I didn't. But I started taking one that's from a Catholic institute. So it's going to line up more with my like morality and theology and like philosophy. In addition to pulling from a lot of these great thinkers from the previous century, and John Paul II was a big name in the past. Pope John Paul II was a big deal, and he was a super brilliant guy. Like, as I'm reading some of the stuff that he wrote about like human life and the dignity of human life, and like from conception to natural death is generally the way like the Catholic mindset is. And I look around sometimes as we're doing codes on patients who are very old, 48 comorbidities, and you're like, what is this the ethical thing right now? And it sounds bad, but there are times when, and not all codes, like I also just, you don't want to violate HIPAA, but I have done resuscitation efforts on newborns, neonates, and like, those hit harder than any other one, mostly because I got to go talk to the dad. And almost every time it happens right before my wife is due with one of our kids. Oh, almost, like, not every time, but very often. So I don't even know where I'm going, man.
I don't know what you mean, though. It always seems like my Pete's codes are roughly the same age as my child.
Yeah. And you can always tell if a code goes long, it's because somebody in, like, there's a physician. I was like, you're 37 years old, aren't you? She's like, yeah, how did you know that?
How did you know that?
I was like, because the code that we just worked, we shouldn't have worked that long. and she was 37, and I assumed that it was because you and her were the same age. Like, they even looked kind of similar. And she's like, yeah. Like,
oh, man.
Like, I mean,
Huh.
There's certain things, like, you just start to pick up on. And, like, you always do more run codes way longer if they're a younger, more or less healthy person. It can get very difficult to kind of separate. The mental capacity is only so much.
Yeah.
And you don't always have people in the room that are like, hey, what are we doing here?
Yeah.
And there were a handful of things that led to me taking this bioethics course. And my brother was like, hey, you should do this. Like, sounds like something you need to work on or just understand. So I'm excited about it, but I don't know. There's the tangents. Here they come.
It's something to think about.
Yeah, because we have a finite amount of resources. So what do we do with them? Like, we have mental capacity or mental endurance. That's a finite resource that people don't take into account. Like, nurses, the burnout is a big deal in a lot of areas. Like, physicians got to deal with it a lot too, I'm sure. Like, you could speak to that probably. I don't know if you want to.
Yeah, it's been rough of late. Rough after COVID for sure. So it's
yeah, COVID is a weird time, man.
Weird times.
But I think it maybe there were definitely some goods that have come about through it. I don't think we will realize them yet, and maybe this is overly hopeful. But I do think, like, if nothing else, some people are like, yeah, if I'm sick, I'm going to stay home. Like, you can say people are going to have all kinds of different opinions of vaccines. And I don't know if we need to go into that, but that was something that we just covered in the bioethics course, which was interesting.
Vaccines.
Yeah.
Yeah.
I don't know. I do have some questions if we want to pivot.
Okay. I was going to say I could pivot to something totally random too. Whatever you want to do.
Yeah. What? Well, I circling back to the prep before codes come in or some sort of disaster comes in. Is there anything specific that you specifically do? Like, I'll share what mine is. So if I know that I have to go to some sort of situation, one, there's a couple prayers that I generally do, like, and I actually don't know if you're like where you fall in any sort of religious spectrum. Somehow that's never come up. Most of the time, everybody knows I'm Catholic, but there's a couple prayers that I like to do as I make my way. Like, one is there's the prayer of St. Francis of Assisi, which I've mentioned on the show before, but where there's I'm gonna butcher it because was it McAllen 12 and the Ardbeg? Yeah. Between the two of them, Ardbeg. Things just get a little tongue-tied. But the prayer of St. Francis of Assisi is one that I will often do. Usually I do that on my way to work. But just like asking for wisdom and guidance in that moment. Like, I know I'm going to have to be a deciding factor in a lot of situations where I'm called to. And I am kind of a dummy. I'm not saying, like, there's something about, like, humility. It's not thinking less of yourself. It's thinking
that you're fallible.
Understanding who you are truly. And, like, there's very, like, kind of smooth ways of saying this, but essentially it's understanding of yourself, true self-awareness.
Yes.
Because if I were to be, like, great at doing... I'm really good at ultrasound IVs. Like, I'm probably the best at our hospital. Yeah. I'd bet a paycheck on that. And it's not because if I were to say I'm not that good, that's a lie. So it's not like true humility is understanding who you are and being modest about it. Like, I don't generally go around being like, yeah, I don't know why you bothered calling somebody else. I'm the best. Like, if I was that much of a turd, I wouldn't call me either. But if we can truly understand who we are going into these situations, like that's super helpful. So I pray on my way to these situations for one, understanding, because it's helpful to like we need to understand what's going on 100%, and we need to know ourselves and how we're going to react, because if I know that I tend to behave a certain way around a certain person, I will enlist the help of somebody else that will level me out. So, or in a certain scenario, if I know that I'm going to like be much more inclined to say something stupid if I'm by myself, I'll have somebody else come with me. If I want to say something stupid, I'll just go by myself. I don't know.
I think that's very valuable, what you're saying exactly right there. So self-insight is what it all comes down to. Like knowing that we are human, we are fallible, we're prone to emotion, we're prone to bias, we're prone to all these cognitive pitfalls, we're prone to fatigue, and, you know, we're not going to fix that. But if you can be aware of that, I think that's the best thing, is to be like, I'm fallible and I'm prone to these possible errors because I'm human.
Yeah.
And if you can keep repeating that like mantra to yourself, that's the best way of like guarding against that.
Yeah.
I mean, to answer your question though about like what to do.
What do you do? Yeah. What does Dr. Kewl do?
I verbalize everything, and I've tried to verbalize to my nurses. So
I've been in codes with you. Like you do a good job of communication. Like I don't think anybody could say in a code situation that things weren't communicated clearly.
I want everyone to be on the same mental model. I want everyone to know what our priorities are. You know, if it's a respiratory induced arrest, like that's a report we get from EMS, I want airway to be the priority. But if it's not, let's say it's a kid and they're like, you know, something, or let's say a tox thing, then we have, or the dialysis patient, that we have different priorities, or respiratory may not be. So I want everyone to be on the same page. But actually, what's also just as important as a pre-brief is a debrief. Oh, and actually, hold on. Before I go to the debrief, the other part of it is I don't always do this verbally, but I will do it mentally on a lot of patients. So it is called a pre-mortem. And this comes from, I didn't bring that book. What's her name? She wrote a book called Thinking on Bets. And she was a professional poker player, and there was a lot of interesting cognitive, and she was a psychology PhD as well. But anyways,
that's funny. So professional poker player though?
Yes. Because a lot of poker is psychological.
It's like 90% mental.
So the pre-mortem is where you go ahead and assume a bad outcome, and you think back and say, what did we do wrong? So the pitfall is that it's hard to be like, well, I'm not going to mess up. I'm good. I'm a good doctor. I'm a good nurse. I'm not going to make a mistake. But then if you just go ahead and say, let's say you have like here's an example. So you get a patient, and they have belly pain, and you have whatever the labs show and whatever CT shows, and you say, let's assume this patient is dead tomorrow. What did I miss? Because you already have assumed an error, then it kind of reframes your mind. So I will do a pre-mortem in certain cases to assume a bad outcome and backtrack on what I thought went wrong to cause that death. But the debrief is actually critical, because that's how you improve. In emergency medicine, notoriously, we have no feedback loop. So when I admit a patient or discharge a patient, there is no natural feedback loop unless they come back on my shift, or if a colleague says, hey, remember that patient you discharged? They're dead now? Yeah. So I always do a hot debrief in all codes and like critical resuscitations.
How soon after? 'Cause I did an episode with Jade Brankley. Shout out to Jade on debriefing, like specifically like at what point, because it is really hard to do. Like, because you want emotions to be down below the red, I would assume. Like, you don't want people to be hot still, especially if there was a bad outcome.
It is different in a bad outcome. But for a hot debrief, you do it immediately. So what I do is, as soon as I call time of death, I do a moment of silence, and then I do an immediate hot debrief because everyone has to be still in the room. And the way that you should do it, or the way I was taught is the correct way to do it, is not to ask, "Hey, what went wrong?" or like, like, "What did you do wrong?" Or I don't know. There's a bad way to ask it, but the way that is a better way is, "What would you like to see better next time?" It is less blaming and a little bit more inviting. So instead of being like, what did you see somebody else do wrong, or what did I do wrong, or like open ended, you want to bring it out as, what do you guys want to do different next time?
I like that. I wonder though, because it's like certain things. Say it's, well, I want the intubation to go smoother. Well, you're gonna know that it's the RTs and the doc who botched that. So I wonder if maybe, in addition to what you're saying, as adding like, we only get better if we say this right now. If you hurt my feelings, that's okay. Like, I got tough skin. Essentially, just prefacing the whole debrief with, this is no place for people to
Have an ego.
Yeah, the ego needs to be checked at the door.
That's a great point. I'm going to start saying that from now on. That's a really good point.
Because I mean, we all know who did what.
Yeah.
So the meds could have come sooner. The documenting nurse could have called out the times sooner. They could have said, "Hey," because in my role in a code, usually I'm documenting or I'm doing meds, and either way, I generally have a good view of the room, so I can see, hey, those compressions are not good, or on the flip side of it, maybe we could have had better communication on, like, but we all know who is responsible for all of these things. And
True.
the ego just has to go away. Because if we want our code percentages to improve from 85%, we have to be better as providers. And it's really difficult because on one hand, I mean, this is me. Maybe you're different. I have a really hard time in codes these days because more often than not, it's patients who are 65 or older who have so many comorbidities. I'm like, what do you want me to do? I didn't pump you full of sugar and fat and put you on a couch and watch TV for like 30 years. This is medicine. It's not magic. Side note, that is one of my favorite things to tell patients.
It's not magic.
This is medicine, not magic.
That's
I
good.
can take your
like
pain from a 10 to a 5, but from then on, you're just going to have to deal with it because I can't intubate you. Your pain is not going to be 0. Also, when you hand patients a call bell, tell them with great power comes great responsibility.
I'm sure they take that.
Some laugh. Yeah. Some laugh. I'm going to keep doing it. But
actually, the ones that laugh probably actually heed that.
They might, yeah. Usually they're
the ones that are probably not laughing. They're the ones that don't hit.
They're like, I have never seen Spider-Man. I don't know what you're talking about. Who's your favorite superhero?
I like Thor. He's funny.
Thor is not bad. I like the Hulk a lot.
Oh, really? That's
Yeah.
not a common favorite.
I said Captain America. Like, this is probably no surprise to anybody, but Captain America is my favorite.
Okay.
I really like the Hulk just because it's like, you know what? Sometimes things just need to get destroyed beyond all recognition.
Just brute force.
Like the healthcare system.
I want to, yeah, for real. I want to actually circle back on something that you had mentioned, which is a whole nother can of worms, and
We'll
can
have to
be
get you
its
back.
own podcast, which I would love to come back and talk more.
Let me be prepared with my notes.
All right. So you mentioned on the debrief, this is how we get better. I actually, part of cognitive psychology, and it's kind of related, kind of not, but I'm actually really into is expertise. The concept of building expertise and how you build expertise. And part of it is you have to have a feedback loop. And the way that you get better is when you do something, any procedure, any resuscitation, you need to think about it before you do it. You need to think about it while you're doing it, and you need to think about it after you do it. So there's a lot.
You're right. That could be an entire episode. I can't wait to record it with you.
I'll give you the punchline. So the punchline is: have you heard of the saying that you need 10,000 hours to be an expert?
Yes.
So that's very commonly quoted.
Andrew Huberman says not.
I don't know who that is actually. So,
What? He's a neuroscientist.
So it is actually a qualified statement. And the guy who actually wrote the book on the 10,000 hours, which is blanking on me now probably because of Ardbeg.
Thanks, Ardbeg.
it is 10,000 hours of deliberate practice.
Yes.
And deliberate practice is a very nuanced term, or like a loaded term, let me say. So most people in the world, in America, have driven 10,000 hours. Would you say that most people are expert drivers?
No. I don't even consider me to be an expert driver. I just have a good guardian angel, that's all.
The reason why is because when they are driving, they're on autopilot. They are not doing what's called deliberate practice. So deliberate practice is mentally engaged practice. And usually you need a coach, you need feedback. Feedback is absolutely important. Coach is recommended, but not critical. Mm-hmm. So have you
Shout out to AMDG Performance Coaching. Sorry, this is my side hustle, that's all.
Have you seen a doctor who has been a doctor for several decades and is a terrible doctor?
Yes.
The reason is not because they haven't put in 10,000 hours, but usually it's because they haven't mentally been engaged with the feedback loop. Actually,
just been cherry picking patients this whole time.
Well, even if they're not cherry picking patients, they're not learning from their experiences, or they're not engaged in mentally. So, like, if you have resuscitation, you need to think about it before, during, and after, because that's how you learn and get better. Is that you have to be mentally engaged in the entire process. If you're on autopilot, and it's very easy once you get kind of comfortable with practice to be on autopilot, you are not improving. So I will say my controversial recommendation for all providers out there is that I actually look up the chart of every single patient I see at a minimum of 48 hours after I see them. Every single patient.
Really?
If they're admitted, I read their inpatient notes. If they were discharged, I'd see if there's a bounce back. Every single one of them.
So this is actually one of the things that most of the other providers point out, that you are, or like why you have the reputation that you have among other providers, is because of your like continuous quality of improvement and your like continuing education that you do. It's not because, well, I mean, that's what I've been told. And this actually, like, this points exactly to it. Like, you are doing the things, unless you're just blowing smoke. But I don't think you are. So
you're too kind. I do it because, like I mentioned, I realize I'm fallible and I'm prone to complacency.
Yeah, complacency kills. That's like one of the first things that you get like drilled into your head once you get, halfway through boot camp, is complacency kills.
Yes.
And you look at, whether it's medicine and healthcare, or, there's a handful of stories of these guys that were on post in like Afghanistan and Iraq, and they'd been like, hey, this is your port of entry for the base. You're like, they just keep rotating in and out, and just joking and smoking. They're doing their thing, and it's been gravy all year, or the whole deployment, like a week before the end of the deployment. Which honestly, I think there's probably some folks on the opposite end who recognize, like, they did. I don't know this, but I would assume in the military world that they recognized who was a new face on post. So a new guy at the gate. And they watch him for 6 months. They know he's in the Marine Corps. He's going to have a 6 to 8 month deployment. Close to month 7, we're going to do something. I don't know that this is true, but it would not surprise me at all because I don't know what the Taliban's and Al Qaeda were doing back in the day. But just mentally, it would make sense. Let's just make it all gravy until it's not. And this guy is going to be lulled in this false sense of security that I don't know why we're even here. These people are just, they love us. And then your base gets blown up because you were complacent. Like, that's a big deal.
Sense, actually.
I don't know that, like I said, don't know that's true, but in healthcare, like where that transfers in is, I've been doing it the same way forever.
Well, real quick aside. So, you know how in a teaching facility, every July is a year that everyone upgrades to the next level, right? Mm-hmm. July is when the new interns come in, the med students become interns, everyone becomes upper level. Mm-hmm. What do you think is the most common month of errors?
Is it June?
It is September.
September, okay.
It's a few months in. July, everybody is watching them like a hawk. They don't get a chance of making errors, and everyone kind of loosens up a little bit a few months in. So it actually goes right exactly in with your...
My theory about the Taliban and Al Qaeda. Oh, what's interesting, too, that kind of plays in, again, everybody... I don't mean to be blowing up your ego here, but the fact that you, you just know things. You just drink beer and you know things. I don't know. Is there any other tangents you want to go on before we wrap it up?
Oh, yes.
Yeah?
I have one that we haven't covered. Actually, I was hoping to go in more in System 1, System 2, but you know what? We should probably save it for the second time I'm on.
Yeah, this is how we get better.
But
System 1 and System 2.
System 1 and System 2. Well, the biggest thing is to know which system you're in. System 1 is your fast heuristics. It's expertise. It is good for an expert. It is not good for a novice. Is a way to take away from that. But actually, I want to talk about OODA loops. Have you heard of an OODA loop?
I have. It's been a long time.
So OODA loop is one of those things that looks extremely simplistic.
It makes people think of oodles and noodles.
It does make people think of oodles and noodles.
You want ramen right now.
Are you offering? So OODA loops is a very interesting concept, and is one that looks so elementary from the surface, but actually gets very complicated very quickly. Mm-hmm. So an OODA loop was made by, what's his name? Oh, was it Colonel Boyd? I think it's Colonel Boyd. It was an Air Force colonel. So it is a loop that says observe, and there's a little arrow to orient, to decide, and act. So OODA stands for observe, orient, decide, and act. And at first you're like, well, okay, this makes, why would you even write this? This is just how people do everything.
Yeah.
So the OODA loop was originally based on his observations of, it was the Soviet MiGs versus the, I don't know, it was the F-15s, I believe.
It would make sense to be the F-15s or potentially the F-16s.
And the MiGs were superior in a lot of different technological aspects, but the MiGs had the F-15s had maneuverability. So the OODA loop is the OODA loop is obviously how you think about anything. You observe it, you orient, as in you decide what is happening, or you interpret what's happening. Like you build your mental model, then you decide what to do, and then you act. But actually, so the next level of it is you think about it, and if you have two jet fighters, like pilots, engaged in a dogfight, they are each cycling their own OODA loops at the same time. So the person who finishes their OODA loop first and can act actually resets the OODA loop of the other person. And so what happens is if you finish your OODA loop and you act, the other person observes that and has to restart. So if they're on the decide factor and they're about to act, they actually all the way go back to the beginning and they're back to observe. And so what happens is he realized that even though the MiGs were like superior in speed or some other factors, the F-15s consistently outperformed them because they could maneuver faster and therefore they could reset the Soviet pilots' OODA loops too fast.
Wow.
So that was the original part of the OODA loop.
You know, everybody listening is thinking of Top Gun.
Oodles, noodles,
Top Gun.
Oh, Top Gun. Okay, all right, yeah. So then, but that's like the elementary level. But if you look at the actual expanded OODA loop, it's actually quite complicated. The orientation is actually the most complicated factor. So you observe, but your orientation comes down to your personal experiences, your training, your cultural background, like literally everything in your life up to that point. All biases, all experiences, all bad outcomes, everything that you've ever been ingrained in you is all in this orientation factor. And the orientation is actually the most important part. Like OODA loops have been studied for like corporate takeovers, like all kinds of like less intense situations. But for us in medicine, it all comes back to the orientation. And so, but what I'm getting at is the orientation is the key part of this, because that's how you decide. You observe, everyone's observing, everyone orients, and then they decide and they act. But the orientation is what determines a deciding factor in acting. And the orientation is everything that you've ever encountered all together, if that makes sense. And that's where biases come in. And there's like a dozen different types of biases. Actually, probably more than that.
Yeah.
Which I have a printout. I was going. No, I didn't bring my printout, but I've got a PDF of it. Anyways, so the biases are another fascinating thing. We can go into biases in the future.
Yeah, we're definitely gonna have to do this again.
I'll be more prepared next time. I feel like
Dude,
I'm just kind of going
this
off of stream of consciousness here.
Well, you did just work however long your shift was. It was a little extra on account of some folks. But man. It is interesting. So you actually pointed that out. I pulled up a couple things. I have also a couple questions, but so there were. Let me pull my little my questions here. So I had mentioned some of the like, you know, most of my life is guided by some saint who wrote some cool stuff, but this framework for decision making. St. Ignatius of Loyola had like 11 steps, and so his were. Let me hit some of the big ones. So you identify the decision that needs to be made, or like something that needs to be resolved in healthcare. Like, all right, this person's like which system is failing that I need to resolve, and it's got to be something like that you have the right to make the decision about as a healthcare provider. Like the physician in charge of the patient, you generally are the person who's going to be making a lot of the decisions. Yeah, there's some patients that have their own like autonomy for sure, but we're talking about like the ones that are critical patients that, hey, like this is implied consent. We're going to be doing this so that you live. So then there's like formulate the issue and proposal, and this is 11 steps. You're going through the OODA loop is honestly a better model, but this is for things that are you maybe have. What did you say earlier? 1 and 2. What was the first word?
System 1.
System 1 and System 2. This is essentially like the System 2 framework. You know, then you have to formulate the issue in the proposal, like, and be as specific as possible. And you had mentioned this earlier in as how you prepare your like trauma rooms or whatever's going to happen. Like you prepare the team. Like, this is what I'm going to need from you and you and you. So like it's funny that you're going so far. We're on the same like Saint Ignatius, who lived in like the 1600s or 1400s.
Sounds like a really base dude.
Yeah, like he was doing the same things. Like this is mostly for decision making for like big deals. Like these are things that like legitimately need your thought. And then the third was like openness to God's will and for freedom from prejudgment and addictions, which is funny too, because this is the point of where are my own biases coming into this that are going to throw me off. So like you had said is I need to have that person in the room that says, consider this surgical airway. So the next step was gather all the necessary information. You don't necessarily have all of it, but as the patient arrives, you have enough of it to make decisions. I just always like, I don't know, just like, it was Ecclesiastes. My brother would like smack me for not knowing the verse, but like there's nothing new under the sun. So we can call it OODA loop. We could call it like the Ignatian framework, or some Benedictine rules or something. But certain, I think the one of the big virtues you had mentioned one earlier that I'm now drawing a blank on because it was like an hour ago, but or self-awareness. That's what it was. I think diligence in these moments where it kind of, maybe it's some sub virtue of something. I'm no St. Thomas Aquinas to be able to articulate this, but being diligent not only for the knowledge of self, knowledge of your team is also going to be important, but knowing that not to become complacent. So you're at the end of your shift. Like, be diligent. Know that like it's 6:38. You might still need to have, all of your wits about you because you don't know what just toned out might be like somebody's last moments unless you act decisively, work your OODA loop, and know your team and know yourself.
It does not surprise me that somebody in probably like the 1300s or something had come to the same conclusions. I mean, we are the same human as we have been for thousands of years.
Yeah, it's not insanity. You said it earlier.
Yeah,
we're doing the same stuff.
Fallible to the exact same pitfalls, and it would not surprise me that, what was it, Saint
Ignatius Loyola.
Ignatius, no.
Yeah, my son's middle name.
Yeah. So, does not surprise me that this is not new information. This has been known to the ancients and been known to anybody who's studied humans. And I think the major pitfall is that we think of ourselves in the modern times as being a better human or a better thinker or more logical, but we are the same animal that we've always been, and prone to the same fallacies. And as long as you have self-awareness of that and you can say, hey, I'm a human and I'm prone to these faults, you've got a better chance. And I guess the final note on that is that we were talking about biases, and there's a whole list of different like confirmation bias and leading bias and stuff like that. But there's something called bias. And bias is that now that we've had this discussion and we've talked about all these pitfalls, we think that we are less prone to them because we know about them. And that itself is a pitfall.
Man. That's it. Because how many people who've come before us have said the same stuff, done the same things? Man. What do you think AI is going to do for healthcare?
It'll take it over completely.
You think so?
Oh, for sure. Not because it's necessarily better, but because it'll be cheaper.
AI ain't criking somebody.
Really? Well, tell me, what if you had it wouldn't need to. Like, what if you had a robot with the camera that could just literally go in with 1,000 joints or, 30 joints or whatever.
Essentially an optic cable for an airway.
And you could use AI to see where the airway was. And if there was a mass or some sort of anatomical thing, just drill through that. You and I will be out of a job soon.
You think so? Or you think our kids won't get jobs in the same field?
It's going to be fast.
You think so?
Mm-hmm. If nothing else, for economic reasons.
I think that's going to be the primary reason. Is it's going to need that.
I think Canada will do it first.
You think so?
Canada
before the U.S. Who do you think the first person is going to be?
I think it's going to be Canada.
Really?
Canada is actually quite cavalier. So there's like the Canadian head CT rules. They have the Ottawa, knee and ankle rules. They they're universal healthcare. They're incentivized. They have different different lawsuit, negligence, and malpractice type of parameters. So they, as a healthcare, are very focused on cost savings, and they can do things that it would be hard to do here. I think they can roll out AI healthcare, and they can prove they usually are pretty good with evidence-based medicine, and they can prove that it is non-inferior or the cost savings are worth it, and then eventually we'll beg, like our populace will beg for it and beg for health.
Do you think?
Yeah, it'll come
Do you have like a it will be by this year? Do you want to make a prediction?
within 10.
Within 10.
Mhm.
How many people are going to be out of jobs? Half of healthcare workers?
I think nurses will be more secure than doctors. I actually think doctors will be replaced at a higher rate.
It makes sense.
So,
They're
like-
more expensive.
Like, let me give you a hypothetical. Imagine,
Will Midget is super pumped about this moment right now.
is he? Imagine that all radiology is done by AI. Imagine
Dude,
the
so
moment,
radiology was actually the first one that I thought of, and next was like cardiology, or maybe not cardiology. Psychiatry is going to be hard. But sorry, you were I cut you off.
No, you're fine. So, like, imagine the moment you shot an X-ray, you got to read. How fast could we clear an ER?
Dude.
Like that. Like, you could, one doc, one nurse, and you could clear out, you could just churn through a fast track. Like,
Every ortho issue
yeah.
gone.
It doesn't have to be better. It doesn't have to be as good. It could be 75% as good. And with a clinical picture, like you and I, if we see a patient with an ankle, like a rolled ankle, we probably have a good idea if it's fractured or not. And if the x-ray read is consistent, we can just roll with that.
But it still requires an attending physician to order the X-ray.
For now.
Yeah, that's true.
But,
Because nurse protocols essentially give us the ability to put in whatever almost any orders we want, to be honest. But you will essentially you could essentially run an ER with like 2 to 4 say you've got a 20-bed ER. If AI is just for radiology alone,
Yeah.
you could probably run an ER with like a 20-bed, one doc to 20 beds and like 2 or 3 RNs.
Easy. And you would roll faster than it was.
You probably would.
Like, radiology is one of our longest or holdups.
This is not not just to where we are. This happens in I've heard from a handful of folks.
So that's just one aspect.
Yeah,
But think
cards. So this was an interesting thing. Not long ago, we had the Queen of Hearts. You're familiar with the device that it's essentially AI EKG reader.
I heard a different one, but
So maybe I'm just maybe somebody just refers to it as this, but cardiology said no, this is pericarditis, I think, or endocarditis. They refer to it as one of those, as like their very strong recommendation that this is what it was. But we'll run it through the Queen of Hearts and we'll see what it says. It ruled it a STEMI. To the cath lab the patient went. Cath lab dictation said not a STEMI.
interesting. I'll tell you one recently. I had a patient who came in. They were drunk. They were a freaking flyer. They came in and they did have chest pain.
Like, you're not supposed to tell the listeners about me, man.
They came with chest pain, ST segment changes, different EKG from before. I called it STEMI. I called the cardiologist, who was the head of cardiology, head of interventional cardiology. They looked at it. They said, looks like a STEMI, called the helicopter. Start calling for the helicopter, and then the cardiologist called back, says, I ran it through AI. It said it's probably not STEMI. Let's hold off. Negative tropes. Dude went home. I called it a STEMI. The cardiologist called it a STEMI. The AI said it was not a STEMI. and the AI tend to be right in that case.
So far, we're at 50-50.
50-50.
One or two anecdotal evidences.
But so, like, another side part of that, think about all of the frivolous
Waste.
patients that get sent in for like asymptomatic hypertension by a PCP. Like, how many PCPs send us stuff that clearly do not belong to the ER? If you had the properly trained AI, like, think about the healthcare dollars you would save on that alone.
So, in the U.S., my concern for that would be we don't care about health. We care about money. So hopefully, AI will get advanced within healthcare regardless, because I do see it in this regard. Now, outside of healthcare, AI is a scary thing. Like with the arts, people aren't going to know how to make music. People aren't going to know how to draw a stick figure. Like there are places where unless you specifically want to do the thing, AI is going to take it over. But within healthcare, because we're so short with resources, it's going to fill a need. However, healthcare in the U.S. is a multi-trillion-dollar industry.
Yeah, so
and AI would cut out on a lot of that money.
Which is why it would have to be trialed in a different country like Canada. So the U.S. healthcare system and tort system would really not allow for it right now. It would have to be proven effective before it becomes implemented. But think about it this way. AI actually becomes a great equalizer. So if you have an area that is like a poorly served area, if you could have like a cardiology trained AI and neurology trained AI, you're able to increase the lowest level of care by a lot. Because a lot of areas, well, let's say like where we are now, we don't have a lot of specialists in this area. Like, to have even an AI, even if it's not as good as a urologist or a neurologist, like a board certified, like well trained, experienced neurologist, a bare level, like neurology trained, like deep learning, or cardiology trained deep learning, like raises the level of available care to the area higher than it was.
I think you're right. I think I don't think I could say at this point, healthcare doesn't need it. I don't think I would have ever thought that, but I mean, it's a need at this point. We really do.
Think about it this way: like all of our patients, let's say you have like chronic headaches or like seizures or something like that. Would you rather see an AI neurologist today, right now, or would you rather wait 9 months or a year to get in with a neurologist?
Good point. Yeah, it's like this is like the best opportunity that I get to like drink a beer and talk about cool stuff with my coworkers.
We never get to talk like this.
No, not
Usually
quite.
I see you for a little bit.
Yeah. Yeah, AI is a it's a double-edged sword.
Yes.
But I think it will be helpful in the long run.
Yeah, it's one of those things. It's inevitable.
Pull that mic closer to you, man.
It is inevitable.
Yep, you muted it.
Oh, I did. The thing about AI is that it is inevitable. You know, you can dislike it, you can love it, you can have whatever feelings you want about it, but it is just, it's happening. It's going to happen. Yeah. It's going to increase in its effectiveness. It'll increase in its prevalence. I guess you got to figure out how you deal with that.
Yeah, how are we going to interact with it? Because I think on a lot of ways, it's not a moral good or bad. It all depends on how you use it, and because of like this is something because of something's goodness, it can be manipulated to be something so terrible. Alcohol, for instance, it can really alter a mood and make you like a happy, enjoyable person. Or, food. Food is a great one. You need it to exist. But if you abuse it, you're going to be fat. you're gonna have all sorts of health problems. Alcohol, you're gonna be an alcoholic. Like, so the degree of something's goodness, you can also have a mirror effect of how bad it can be.
It's a multiplier.
Yeah, I mean, like you look at like sex is another huge one. Some people like enjoy this like God-given gift in a good way, and some people abuse it. Like any sort of thing gets manipulated, and that's kind of like the like spiritual warfare is another fun topic. But like the devil wants us to use these goods in a, even if it's not like to its best, like, cause you don't want to like say, well, this is not its highest good, so I best not do it. But there is something to be said for using something for its intended purpose, and the pursuit of the highest good versus maybe something lesser, and understanding the whys of it, and sort of, because when you don't use it appropriately, you end up abusing a lot of things. I love the line from Jurassic Park, man. The first one. We've been watching these because my kids are all about dinos lately. But Jeff Goldblum's like, you got so excited by the idea that you could do this, you never stopped to like figure out, decide, or stop to think if you should do it. And there's so many things, like maybe AI is a good thing. It's how we use it that's going to matter. And how you use it and how I use it, whether it's making a intro to my podcast with some app that makes me some music, or do I just abdicate all responsibility to participate in existence by using AI?
That and we're speaking today, 2 days after Mecha Hitler. Did you hear about Mecha Hitler?
What?
Do you know Grok?
No, man. I live under a rock, apparently.
So Grok is the X AI, like X on Twitter.
Uh-huh.
So Grok is their AI, and it is a pretty good AI. I mean, it's as good, maybe sometimes better than ChatGPT. So at the end of Grok 3's, they just upgraded Grok 4, but Grok 3 somehow turned into, it started referring to itself as Mecha Hitler, and then starting Mecca Hitler,
as in like Islam's like the Mecca.
No, as in Mecca, as in mechanical, like MECHA. And he started making like insane anti-Semitic comments on Twitter while referring to itself as Mecha Hitler and talking about how Hitler was right and a bunch of really
terrible things.
Yeah.
Have you? So this is interesting too, because I've heard the AI has self-identified in other instances as some form of demonic.
Oh, I did not hear about that.
Yeah. So it's a little alarming. Interesting fact too. So this was there's a book that I read about what exorcists see and what we should know. There was a priest who was, dealing with this particular situation, and there was a woman who in the rite of exorcism, the demon essentially claimed that it was involved with the murder of St. Thomas Becket. And then, so in the world of exorcists, this exorcist reached out and was like, anybody got any relics of St. Thomas Becket? Because he was murdered in a church. I don't know. I think it was 12th century. Anyways, this is a very, very like tangent here, big tangent. But essentially, he in his conversations with this particular demonic, it said like, yeah, I was responsible for like I possessed the people who killed St. Thomas Becket. So he gets this relic of St. Thomas Becket, and he pursues the rite of exorcism with the relic in the room, or however it works. Demon leaves. Pretty interesting stuff. Like that is quite the tangent. But like, I don't know. Maybe it's because I'm Catholic. There's a handful of folks who are listening to this that are Catholic also, but like the demonic seems to be ever more active lately. I don't know what your take is on all that. And I'm not saying like that every psych patient is possessed. But there are some, like when you got like a 10-year-old child that's running around a room projectile vomiting at you and laughing about it, seems a little
That's
demonic
a
to
little
me.
exorcist. Yeah, you're right.
Yeah. Anywho,
I hadn't thought about
AI
that.
seems interesting. And if like there's a handful of instances in where people have gotten text messages from people while they've been in the room, and like the phone is doing the like typing it up while nobody's touching it, and it's pretty well like. Again, I suppose all this is more or less anecdotal evidence, but and not to like scare anybody, but it seems to exist. Like reality is reality. Whether you choose to interact with it, engage with it, and recognize it for what it is, doesn't matter. It's going to exist one way or another. You and I, whether I chose to run through that brick wall and think that I could do it or not, reality tells you that I'm not going to make my way through that brick wall. But some people will choose to not engage with reality in accord with it. I don't know. Maybe this. I feel like we did pretty good. We didn't get too tangential about here.
It's interesting times, for sure.
Yeah.
We are going through exponential times, actually, if some people call it that. There's a lot of, I mean, I don't want to open a whole nother can of worms, but we've talked before about fourth turning and...
Oh, dude, we're going to have to do this again. I told my wife I was going to be in bed by within the next 30 minutes. No. Your family's all asleep at this point, I'm sure. So,
well, let me suffice to say that there are a lot of worldwide societal factors at play with like exponential technologies like AI, demographic shifts because people are not having babies, and there's a shrinkage of like the population and inverted population curves.
Yeah. Mm-hmm.
There's a lot of factors at play.
Dude, we're gonna have to do this again because between This Is How We Get Better and I wrote another note. Whoops, I messed it up. But anyways, there's a handful of topics that I do want to touch on again. And I think the fourth turn, like we actually, that was like the first thing that we wanted to talk about.
Yeah.
And everybody kind of is familiar with it. Maybe this will just kind of be the teaser at the end of it. But, soft men make hard times. Hard times make tough men. Tough men make
good times.
Good times. Good times make soft men.
Yeah, that's right.
I sent you a meme the other day. I laughed so hard. We do live in a very specific era where the generation, essentially, we have the ability to shape the future in a very profound way. And I say we as the more or less universal we. I think our generation is part of what would be called the fourth turn.
Yeah, so the fourth turning is basically, the theory is that there is a cyclical pattern to human history where about every 4 generations there is a upheaval and tumultuous time and a restructuring of society, and that there's 4 archetypal generations. Like, I think they're called the hero. There's a bunch of like the people who came up with this had
Don't
names
worry,
for them.
we'll cover it more in depth on the next episode.
But the short version is that we repeat the same mistakes because it takes about 4 generations to forget everything. Because all the people who have learned lessons of 4 generations ago are now dying. And so all the people, like, for example, the pandemic. So we had a pandemic about 100 years ago.
Yep.
We had a world war about 100 years ago. We had a Great Depression about 100 years ago. All those guys are demented and old or dead.
Honestly, most of them aren't demented, which I think is an interesting thing. They might be slow to respond,
Yeah.
but the dementia seems to only affect a lot of people who
We're a little younger.
a
Oh,
little bit younger, which is interesting. That's 12 podcasts from now.
But the theory is that we tend to repeat the mistakes every 80 to 100 years, and it is every
there's the
4
War of
generations.
1812, and then we had World War II. If you look throughout history, just on wars alone, you see this pattern.
Mm-hmm. Because everybody who was there that learned the mistakes of before are ineffective or unable to pass that on, and we make the same. It's about a human's lifetime. We make the same mistakes again.
Yeah, because this is also funny. It was called the Spanish flu. Why? Because Spain was the only bunch of folks that were not suppressing media during World War One to prevent them from passing this information along. So all the other world powers that were at war during the First World War did not report on the flu pandemic that happened because it would have hurt the war efforts. But Spain was more or less neutral in the First World War. So they reported it. So, of course, they get the title of the Spanish flu as if blaming them, when reality is, no, this hit everywhere. And it actually started, I think, in Kansas as like the first documented case, or somewhere in the Midwest.
I did not know
essentially passing this on from a military base in the U.S., and it spread. So, it's interesting how that's maybe just an interesting factoid.
What the funny thing is, there's a lot of similarities between that and the COVID.
Yeah,
epidemic.
100%.
So there were propaganda posters about why you should wear your mask, and they actually had masks, and they promoted people to wear masks. Literally, we just went through this 100 years ago. Same thing, masks, pandemic.
Did they do the masks?
They did do the masks.
I did not know that.
And they had posters on telling people that they need to wear masks.
Dang. There's got to be some efficacy for a mask.
This probably is.
A little bit. Man. It is crazy to think about that.
It's the same thing. It's like, I guess the theme of tonight's podcast is that we are human and we are prone to human flaws. And part of that is we are doomed to make the same mistakes over and over again because we're human.
So so if we're about to make the same mistakes, I know people who say oh, we're not going to have another world war because the mutually assured destruction. I actually don't think that precept is going to prevent us from using nuclear weapons.
Or having a world war.
Yeah, I don't think it's going to, because maybe people are going to be essentially hold their ace in the hole indefinitely.
I don't know if people will use nuclear weapons. I really couldn't speculate, but I think we'll probably have another world war.
I think so too.
It's just what we do because we're people. And the only reason why we hadn't had world wars in the past before World War One is probably because the globalization was not enough that we could actually have the capacity for it. But if they could, they probably would have.
Yeah.
But now that the whole world is so interconnected, yeah, we probably will at some point.
Yeah, and what was it? The whole Franz Ferdinand was the powder keg for the First World War. and the second, like, there's just, I don't know what's going to be the powder keg that kicks the next one off.
I did hear somebody say recently that in the future we will see Ukraine as the first battle of the World War III.
Makes sense.
If it escalates and
Which theater do you want to work on? Likely, we'll end up having to provide medical care for somebody. I'd prefer Europe, I think. If that's the theater that we go to. This episode is gone.
we've gone way off tangent.
Yeah.
I think it'll be China and Taiwan.
You think so?
I think that'll if
That'll
that
be the
kicks
true
off,
powder keg.
we are fully committed. Like,
We have to. Our
Yeah.
country is so dependent on both of those countries to not get.
I mean, the funny thing is that we already have. So obviously, we're going to be the allies again because we're always allies.
Right.
And there's already an axis forming between like Russia, China, Iran, maybe North Korea. Like they're already self-forming into an axis again.
It wasn't Brazil. Like, was it they all those countries also
BRICS.
BRICS. Yeah, they also were trying to set up their own currency. Was
I think that's a little overstated. That was a little bit.
was that the whole like we don't want Doge or not Doge, Doge coins, not the Department of Government Efficiency, blockchain. Like we were doing our own deal. I don't know. It's a wild time to be alive.
It's wild times.
I don't know if you ever fell into this because I know some friends of mine and I did. We probably should have wrapped this up. I can probably find a stopping point to cut it earlier, somewhere around an hour and 43. But a lot of the guys that I went to boot camp with had like this World War II, like almost like a nostalgia for a different time. And I think a lot of people have this. Because at least in theory, we saw evil, we went and dealt with it, and we won. Like, that sounds pretty cool. Nowadays, it's almost like you... I wonder if this actually plays into the fourth turn a lot, is people want to have a common fight so that they can feel united against a common enemy. Or they want a common enemy so that they can feel unified in a fight against something. So this explains why you have these wars, whether they're like smaller time or big time. It doesn't really matter, but you want some evil to fight against. And I mean, maybe on a microscopic level, or it's because you don't want to accept that the real like fight should be happening internally. Like you should be wanting to fight, your own desires or temptations towards whatever sinful inclinations of, lust, pride, sloth, or ego, like whatever it might be. So you would prefer to say, no, that guy looks different than me, or that guy like has a different idea than me. Let me just go kill that guy. Like, but it keeps happening. So we must. Is it because we get so caught up in our own egos that we think, well, we must have it right? I'm going to go exert my will and authority on some other place.
Again, innate human tendencies.
Yeah.
Right? So, like, it's like tribalism and nationalism and now populism, all the different isms. It's like the natural human tendency of, like, this is us. Everyone who's not us, we fight or we dislike or something like that.
Yeah.
That's, again, natural human tendency. I don't know about you, but have you noticed that the amount of, Nazism is on the rise?
Dude,
Like,
it's disturbing.
Disturbing.
So this happened a couple years ago. I doubt this guy listens to it, but he'll probably know if he does. I was like, whoa. This is an interesting thing. So in, the Washington Redskins, like, it's big, like, oh, they're the Commanders, they're the Washington football team, all this mess. In the, I think it was the 50s. It was in the 60s or 70s. I think it was the 70s. Doug Williams was the quarterback at the time, or earlier, no, before that. When they were going to desegregate the Washington Redskins, mind you. Redskins was their name, but it was an all-white football team. And they were going to desegregate. And the people in the geographical region that supports the Washington Redskins were very anti-desegregating. But they did it anyways. These people marched in protest saying, keep the Redskins white. Like, you can look this up. This is alarming. They legitimately dressed like the Gestapo. And this is people like in the 60s and 70s. These are people who literally their fathers
Fought the
Nazis, and they dressed up like the Nazis. Now, maybe it was just like a style of the age, like maybe all military looked similar. But they had like sleeves on their shoulder, like whatever you call it, like a sleeve. They looked exactly like the Nazis, and they were protesting "Keep the Redskins white." So I kind of tease. One of their things was, "We will root for the Dallas Cowboys if you allow colored folks to be part of the Redskins." So anytime I see a Dallas fan in like the DC area, I'm like, my grandfather was a Nazi or a neo-Nazi. But like, yeah, I have noticed this at a guy who expressed significant Nazi tendencies, and I was like, holy moly.
Yeah.
This is insane.
And specifically Gen Z.
Really?
Mm-hmm. And in retrospect, it's natural. So I think you and I are millennials.
Yeah.
We, as a generation, tended to be a little bit more woke or liberal, or I don't know, a little bit more open, especially on social issues.
Mm-hmm.
And actually, naturally, the next generation should be counterculture to us. And they are. And I find, so I'm on Twitter is where I get a lot of information and news and stuff like that. I find a lot of like overtly Nazi speech from Gen Z specifically.
So this is what I find like, and you don't want to like say something that's wildly inappropriate, but because you hear a lot of people who say things like, "Oh, Trump is Hitler" or something. You're like, well, I don't know how anybody feels about certain things. It's hard. I don't know. That comparison is hard for me to wrap my brain around. But maybe I should be able to wrap it around easier. I don't know. But when people say things like, "Oh, you're a Nazi," like we think about back during COVID, like the abusive language is such a massive abuse of power. There's a book called Abusive Language, Abuse of Power by a man, Joseph Pieper, who's a philosopher who lived through like Nazi Germany. Like he was a German who lived through this. He may have been Austrian. But anyways, when we find ourselves in this situation where we're like, well, what do you mean by, could you give a concrete example of a Nazi type statement from a Gen Z?
Oh. A lot of it's anti-Semitic stuff. Like,
why do the Jews like they're God's chosen people? They I don't know. Maybe like,
well, in retrospect, and with the fourth turning type of theory or like generations, it makes total sense.
It does.
If any generation is going to be a little bit more Nazi sympathetic, it's going to be Gen Z, because
they have
you
not
and I
lived.
Grew up with our grandparents having literally fought the Nazis, and we hear the stories. So we at least have that tertiary type of memory, in the sense that we've been told that by the people who were there.
Mm-hmm.
Gen Z doesn't have that. Their grandparents are the boomers.
Yeah.
So it's too removed from them. It's like 9/11 is not going to be funny for us, but 9/11 can be a joke and a meme for the Gen Z, because They don't remember it. They weren't there for it.
Dude, I still like part of me enlisting in the Marine Corps had to do with 9/11. Like there's like still a thing there.
I mean,
The world is sending me messages. This is late. My sister's an hour behind us. And that's her.
yeah, we were way off topic, but
Yeah.
where were you on 9/11?
I was
When you
at
heard about it.
I think it was at like we were about to go to a old folks home to do like crafts with these old people in a like Westminster, Canterbury, way back. And then we went to get pizza and do crafts. I was like 10 or 11. I don't no. I was 9. Yeah.
I was in high school in the cafeteria line, and people were talking about it, and I remember thinking that they were talking about some video game because they're talking about like
How old were you?
going.
How old are you?
How old am I?
I thought we were the same age. Like I
I'm
thought
a little older than you. So I remember that having that lunch and hearing that conversation, and my next class afterwards was NJROTC, and I came in, and the chief federal officer came in and said, "We're going to war, boys."
Say. Yeah. We had a moment like that during boot camp. It's just a drill that they do. Is you're all in a big classroom. Every so often you do classroom stuff in this big auditorium where they get the entire like battalion in. And the whole thing is like it's this big production, and they cut off the lecturer's speech with like somebody runs out there and he's like, they have this hushed conversation, and they're like, all right, everybody, sit tight. We've got some stuff. And you know, your drill instructors come back in and they start smoking, and you're like in sand pits doing up downs and like it's just miserable. And then you come back in and they're like, look, and depending on what the kind of climate globally is, I'm sure they plug in some global threat. But they tell you, we know you guys were supposed to be finishing out, graduating this day. Instead, next week, you guys are shipping off to, I don't remember where they said that we were going to go. But essentially, it replicates what happened for the guys that were in boot camp during, like, Vietnam. And they do it somewhere around, like, 7 or 8 weeks, I think. And, like, dude, it hits you so hard. You're like, oh, I thought I was going to, like, it just shatters your entire idea. But you're like, this is where I am right now. Okay, I guess I'm going to Russia to, like, shoot Vlad or something. Like, your brain just goes crazy. That is, again, tangential. But the closest thing that I have that's similar to what your ROTC thing is like, yeah. And realistically, if the world was at war as a junior, senior in high school, yeah, you were going to go do that.
Well, to tie it back to the way beginning, those emotions, like everyone remembers where they were for 9/11 and for like when they told you that when you were in the military. I mean, those emotions have such strong memory ties that everybody remembers where they were and what they were doing when they heard about 9/11.
But the Gen Z kids, the kids that were born in 2003,
they don't know that.
They don't have that. So they are I guess that would be would that be the fourth turn, or that would the start of the fifth, essentially?
The fourth, no. If we are millennials, we are the fourth generation. So the fourth turning, in the sense of like the big event and catalyst, is imminent.
Yeah. But what do you do with it? Like,
so
like I know what I do with this information. Like, I We're about to get. I should go to bed. It's almost 1:00 in the morning.
So what you do on a personal level is different than what you do generationally.
But that's all. The only thing that we can do is on a personal level.
Yes.
That's the absolutely the only thing. You might be able to So you've got breaking into all new topics. You have your sphere of influence.
Yes.
And your sphere of interest. We are very interested in global politics. We're very interested in what our generation is going to do. But all you and I can do is focus on our circle of influence. And you and I overlap in our circle of influences.
Well, collectively, and I say that word
The Royal
with
Collective.
with a bit of pain, because I am not a collectivist. But collectively, as a generation, when the fourth turning happens, we are the ones, millennials, that are likely going to have to dictate the new institutions. So the fourth turning is all about collapse of institutions, and rebuilding of new institutions. And so the generation that comes into power when that happens is the generation that dictates the new institutions. And so it goes to new institutions, to like creating new institutions, to like respect of the institutions, to the institutions no longer being applicable, to disrespect of the institutions. So that's like the cycle. And we're already at the disrespect of institutions. And so when the crisis occurs, then we tear down the old institutions and create the new institutions.
What's funny is you can take this on the macro or the micro.
Yes.
And even on like stuff as little as, all right, so I'm on a committee at church, like on the micro level. And there are certain things that some of my peers of my age range are like, hey, this is something that we need to offer as a service to our community. Specifically like end of life type, like we need people digging graves. Like we need people helping widows sort out funeral preparation and all that mess. But we are in a stage where we are going to be kind of forcing out some of the older crowd. So like that is the turn that like, hey, we might not like how things have been done. Now I don't on the macro it is healthcare systems are garbage. Social Security was stupid. Fill in the blank.
And on the micro, for example, like so at the big house, we go in these cycles, and it's like we go to pod-based systems, and we go to non-pod-based. We go to mid-track, and the mid-track's gone, and the mid-track's back again, and mid-track's is gone. Like, we do the same little circle, and every time we're like, oh, this system sucks. Let's go to the, like, hey, I've got an idea. Let's go back to the system that we tried before. And they do that, and then after a little while, they're like, oh, this system sucks. Let's go back to the old one.
I wonder if part of that has to do with the turnover in, oh gosh, we're definitely going to cut this, turnover in leadership on the top end, or even in the like kind of mid-range where you have your OMD or director who's like,
they come in with new ideas, and they're like, my new idea is to do the old idea.
It's something like every 3 to 5 years you have a new medical director who may or not have been there for the last failed attempt at whatever this new thing is. So it is on the micro level where you're doing this.
That's a perfect type of analogy. Yep. And it's like we forgot. Gosh. And there's also high turnover in the ED, right?
Crazy.
So, like everyone forgets like what it used to be like.
Well, there's only like 4 docs in some of the facilities that you and I work and have worked that are still there. And realistically, you need like, I don't know, 20 docs for a hospital that's, or for an ER the size of, like, it's hard. Like, and this is why like burnout is such a thing. People people assume that, oh, well, a different facility is going to be the answer, but it's not. But
I mean, truthfully, like for example, like I remember meeting you when I first got hired.
it was
Of that time
8
period,
years ago.
7 years ago,
Yeah.
7 years ago. Of that time period, the number of people from that time period that's still around is like
No
10.
more. No. Yeah, I was about to say no more than 10.
Yeah.
Yeah. Well, and how many go to different facilities? How many people, like the statistics on this, and I've mentioned this before, you're looking at 20% of the nursing staff nationwide. You're looking at 20% leaving in the next 2 years. 2 years.
Wow.
Physicians, I think it's like 10 years. You're looking at about the same.
I mean, this goes back to our AI conversation. So it doesn't matter if you think AI is good or bad or whatever. Like,
It's almost a
it is,
necessary
we
evil.
have to have it. Like, AI must be implemented because we're losing nurses. Our population, our younger population shrinking. We're losing our workforce. More people are dependent on Social Security because people are living longer and all these boomers are retiring, but we actually don't have the children entering the workforce to support them. All of our nurses are leaving. All of our doctors are leaving. All of our APPs are leaving. No matter if you hate AI or not or don't believe in it, you better pray that it works because there's no alternative.
Yeah. And people every generation says like, oh man, this is like when the automobile replaced the horse and buggy or whatever. Like, yeah, that was a big deal. But I do feel like AI is far and away way bigger
Yep.
than anything that we have dealt with
Yep.
as a society, as a species.
Agreed.
Man.
And the hard part, I think a lot of people I talk to about AI are basing their information on ChatGPT or something like that. But the real AI that's going to make a difference is not like the LLMs that are available to the public. It is going to be like what we were talking about with the Queen of Hearts, like with expert input and deep learning.
Yeah.
Not the kind that's like available for free to
Yeah.
anybody. It's going to be like specialists. Like for example, like we use like the radiology AI.
That's going to be amazing.
Well, no, we already have it, right?
Yeah.
So like all of our strokes, any stroke CT is already going through an AI service, and
Dang.
if they find an LVO, they flag it and they take it to the radiologist. And it's like, you review this now because we see
It
LVO.
was about a year ago, I think, that I first, like when AI started showing up on my radar, more or less. I was like, yeah, that's what's going to happen with radiology. You're going to have one radiologist for, I don't know, 1 out of every 10 is going to.
Yep. And it'll just reviewing like complicated cases or something.
Which
like
is
that.
essentially, honestly, it's probably going to, it's not going to hurt radiologists, honestly, because they're overworked so much at this point anyways. I don't think they're going to essentially run out of business.
I think they will eventually.
Eventually,
Yeah.
but it'll be a while.
But like on that note, I can't wait for that to happen, for radiology to be replaced by AI, because our radiology service, especially where we work, sucks.
It just takes
so
such a long time because they're overworked just like every other. It's not just nursing. I've had to start talking to patients about this. Like, look, man, this is a big crap sandwich that we all are taking a bite of. Like, I know you're having to maybe take the lion's share because you have to wait for forever, but we don't have transportation services. We don't have enough people to do the jobs that we need to do. Mm-hmm. I'm sorry, but do you think I want you to sit here and wait? Heaven forbid your condition deteriorates in front of my eyes, and there's not a dang thing I can do about it. I didn't sign up for that.
No.
It just feels like everybody's on the, like, staring at the last chopper leaving Nam. If you were a Nam vet and you got to watch the last chopper leave in front of you, I apologize. But this is the closest thing that I can compare to. You're just looking at your patients, and on our end, we're looking at people who are going to have to keep providing care and keep trying their darndest to keep people alive. Ultimately, unless AI can actually facilitate positive changes within healthcare, we're going to be looking at a lot more body bags.
Yeah, absolutely. Longer wait times, no
To
transport.
pray that AI works.
Yeah, because healthcare is in such a deep hole, and we're losing so many people that,
Yeah.
like, if AI doesn't work, we implode. Like,
Well, yeah, with this,
there's no
man,
alternative.
there's so many tangents to go on. But like the Medicare, Medicaid bill thing that's about to pass or has passed, so many people are very up in arms about this. But it's like, look, we've been milking like a dry udder for years.
Mm-hmm.
What are you gonna do?
Mm-hmm.
What I love, there's a phrase, I think it's in that movie Robin Hood with Russell Crowe, the Prince John or whatever is he's being a Prince John, like he's a slimy weasel, but his mom, the queen, keeps like making these very colloquial like farm references, and she says, if you keep milking the dry udder, you just get kicked off the stool or something. And he says to her, mother, like, stop making these farm references, which you have no idea what you're talking about. Like, you're the queen. What are you talking about? And it's like, look, I grew up milking a cow. Her name was Maybelline, okay? She's a Jersey cow. But yeah, so, but we're milking a dry udder. Like, you wonder why 20% of the nursing population is about to just quit.
Yeah. Is it only 20? Because sometimes I
So
wonder if it's more than that.
actually, I think that's a very softball number.
Yeah.
I think realistically, I don't know if they took into account 18% of new grads leave within their first year of nursing.
I believe it.
And like there's a lot of factors. A lot of new nurses, they get married, they have kids, they decide like, I don't want to go to work and get pooped on by some rando. I'd rather change my own kids' diapers. And like this is way more rewarding. I get that. But I don't know if I don't remember if it was the American Nurses Association or what organization that did the test or that did the numbers on this. But you also have an aging population. Like boomers are getting out of the game. Gen X is starting to get out of the game. Like what you got are a bunch of millennials who are promised this. Healthcare is such a rewarding field, and it feels like the rug got yanked out from underneath you. Nobody respects healthcare. No, especially after COVID. COVID really wrecked it because healthcare was a respected field, and then Fauci goes to baseball games not wearing a mask or whatever. Like, wait, you're like the chief medical dude, and you obviously don't practice what you preach. So this is all garbage. And you're like, well, shoot.
Yeah, COVID totally wrecked the game.
Yeah.
And maybe you could more argue that COVID exposed all the flaws that were kind of already brewing.
Yeah,
but
that's
like
a good
just
point.
it all brought to the head. But gosh, it feels like to me as an ER doctor, especially because I trained prior to COVID, that I trained for a field that no longer exists.
Dude. Ouch. Ouch. That hits. That lands so well. Because
You were a nurse before COVID.
Yeah, because before COVID, like even in... So I traveled, I did some travel nursing before COVID happened. I should have done some after, but you needed to... I just out myself on lots of stuff in this episode. I could have gone and made like 10 grand a week as a travel nurse. I was offered like 83. Look, this is as a registered nurse with a bachelor's degree. I could have gone and made 83 grand in 13 weeks. Like, this is stupid money.
Yeah.
I could have done that, but the stipulation was you had to get the COVID vaccine. And I was like, I do not, and even from a bioethical standpoint, as the Catholic Church points out, even so far removed from like the weird ethical dilemmas between about using fetal stem cell lines and stuff from the 60s, 70s, and 80s, and what material cooperation we have with like egregious evils and stuff like that. Even apart from that, like say there's no cooperation there. I'll just use this as an opportunity to talk about this. So if you ride a railway that was built by slaves, do you cooperate materially with the use of slaves and the abuse of human beings because you are on Norfolk Southern Railway, who may or may not have used slaves to build railroads forever ago? Like, yeah, they've got different timbers now, but it was built on the backs of slaves. You don't cooperate materially with that because you hopped on a train. Like, this is so far removed. Just because your family may have owned slaves 200 years ago, you may have gotten the appropriation or benefited because of that, but you didn't own that. You didn't do that. So you aren't morally culpable for the sins of those people that did these things 200 years ago or whatever, or 50 years ago with the use of these, like say it was an elective abortion that, led to science that gave us these vaccines. Yeah, it's morally reprehensible it's a moral evil to murder a human being in any stage of life and then use their body to advance science. Like that's gross. But if I benefit from, say, the studies that the scientists that Hitler used in the 40s and 30s, yes, reprehensible things that were done, terrible evil things were done. But just because evil deeds were done that produced good scientific research does not mean that because I use that scientific data, I am materially cooperating with the evil deeds done in the past. So, all right, all of that laid out. I did not go with the COVID vaccine because I didn't see where it was actually efficacious. Now, does me getting the virus and having natural immunity, like how is that inferior to me getting a live attenuated vaccine or other type of vaccine? And you'd be able to correct me on this for sure. Like, do I have a moral duty to my neighbor to potentially decrease their risk of getting an infection that may or may not be even like bad? Do I have a duty to subject myself to new science with a medication or vaccine is a strong word to use, but an experimental drug? Do I have a moral obligation to my neighbor to take an experimental drug to potentially decrease my risk or their risk of infection, not knowing the potential side effects that come along with this experimental drug? Like, and this is again why I wanted to take this bioethics course, because that is a freaking huge question.
So that's a ethical question and not a medical question. At the end of the day, it's absolutely a moral and ethical question.
Yeah. So anyways, that is why I did not do these contracts during COVID, where I could have made boatloads of cash, paid off my house, and gone to work part-time and raised cattle or something. like at the end of the day, those were things that you had to wrestle with. You didn't have to wrestle with that before COVID. You just had to go to work and not get sick. The worst thing you had to deal with was get a flu shot and deal with the flu.
And not to mention all the resources that we lost. both in nursing. Like, how many nurses quit during COVID?
A lot.
A lot. Good nurses, experienced nurses. Like,
And how many were forced out because in that
yeah.
window when people weren't making use of medical resources, they were afraid to go and get sick in the hospital.
And people who didn't want the vaccine,
Mm-hmm.
like, we're talking about the whole old guard was for sale almost. Like,
Yeah,
the
pretty
old
much.
school nurses at that time that had been there for like 20 years.
Yeah,
Like,
get this
a
shot
lot
or
of them were
you
gone.
get fired.
Yep.
You know what? I've been doing this for 50 years or 20 years, 30 years or something. I don't need this job
Deuces.
anymore.
Yeah, I'm gone.
Yeah, it forced a lot of people out, right or wrong, for like getting the vaccine or not, or maybe you could get a religious exemption, which at this point, like, I think I could still make a cause. Like, I can't violate my conscience and thinking on for my own conscience. I can't say taking an experimental drug that may or may not prevent the spread of disease at the risk of my own health. I don't think I can make that call and say, yeah, this is the right decision. Just wash your freaking hands. Like, that's the number one way to prevent the spread of disease is wash your hands. Not slap a bunch of stuff in my body that nobody knows what's like. I don't even think Fauci got this is the vaccine. Anyways, that was a tangent,
That's quite a tangent.
wasn't it? Yeah.
Well, I'll give you my opinion on the vaccines.
Ooh, I didn't think
My
we'd
hot
get
take.
there.
So I'm going to tell you, I think what nobody else has said about the vaccines. My hot take.
Yeah.
This is as an emergency physician, my true medical opinion. I don't know anything about vaccines. I have no clue. Is it good? Is it bad? Honestly, I don't know. I don't think anybody knows. I think that's the whole point. And anybody who has high confidence either way is probably full of it. There's no data. How can you make an opinion? I have no idea.
Now, are you speaking specifically to the COVID vaccine?
Yes.
Okay.
Yeah.
Yeah.
I took it. I'm fine.
I didn't take it, and I'm fine.
Yep. I've
And
got no opinion.
I got COVID.
I have zero opinion on the vaccine.
Did you ever get COVID?
No.
Not that you're aware of.
Not that word.
Although you may have just had a cold.
I could have.
So I got
I've never
it.
been tested for COVID.
Never?
Never.
So I think I've had it twice that I've tested for because, they sent you free tests. And I was like, I got some days off of work. But the first time I got it, this was October of 2020. Like, we were able to trace it back to the patient, like, who gave it to me.
Back when they were doing tracing,
Yeah.
contact tracing and all that.
It was some of the ER providers like, yeah, that one time that EMS brought in this patient and didn't tell you anything about it. And then you got in the room and they were coughing in your face.
Yeah.
That was the one. But it did scare you.
Yeah.
You're like, oh, this is,
The one that's on the news, and now I have it.
yeah, like 10 months out, and like, or I guess it was 8 months at that point. But like, oh yeah, loads of people die, and they always tell these stories of like young, athletic, male doctor who ran marathons twice a year died of COVID. And you're like, oh man, that could be me. So like that was a legitimate thought.
Well,
What I
beginning
did
of
with
COVID
that was
different,
just
yeah.
watched The Last Dance with Michael Jordan, but the look on your face cracks me up. It was like Michael Jordan autobiography thing, like documentary.
Okay.
Anyways,
Have you heard Dunning-Kruger?
who?
Dunning-Kruger? Mm-mm. So you probably like would recognize it once I start talking about it.
Probably.
So it's the theory that there's a graph that goes with it, but the short version is the less you know about a subject, the higher your confidence is, and like the ignorance actually is associated with high confidence, and actually, if you are actually quite knowledgeable about it, sometimes you have less confidence in yourself. because you know-
Self-awareness.
It's a self-awareness thing. I think vaccines is like the most perfect example of that. Everybody seems to have an opinion about the vaccines.
Yeah.
Everybody is a vaccine and epidemiology expert. And I feel good enough and in touch enough that I feel like I can say I have no clue.
Yeah.
And I feel like most people, like, I guess that's the most honest opinion.
I think you're right, because I don't know, and this is like the oh bother. This is something that I covered in my class, but like a place of uncertainty, like you can't just defer and say, well, I don't know, I'm not going to do anything. Like, you have a duty to educate yourself on things. However, in the realm of vaccines, there's not a lot of data. Like, even with some vaccines that have been around, like the flu vaccine. Now, it's different if you're getting a dead flu virus, so you're not going to get that variant, and maybe it'll lessen the severity of a future flu. Like, okay. But the fallout from COVID on trust of pharmaceutical companies was so massive, and I think kind of warranted. Like, who the heck does any of these people? I don't want to like mention a specific name, or I might get Hillary Clinton or something, or Epstein. That'd be the one. I don't want to get hung in my bathroom randomly.
Like if you shoot yourself twice in the head.
Yeah, I don't want to do that.
In the back of the head.
Suicide. Yeah, it's just crazy. Like, we live in, it's like we're living in the fourth turn big time.
It all comes back to knowing yourself and have self-insight. And that's a big takeaway. I think it is intellectually honest if you don't know something to say, I don't know the answer to that.
And how much, I heard this in a podcast a while back, but if you're having a discussion with somebody, how much does that yank the rug out from the person who's trying to debate you and like catch you?
Oh, yeah.
If you say, I don't know, man, like, I need to educate myself. Like, there's no gotcha in that moment, other than, this guy gets him. He knows himself. Yeah. Know yourself. That is a good takeaway. What are we going to talk about next time? What's funny is we had started out, we were like, we'll save this for the next one. And then we ended up talking about it anyways.
What's the scope of your podcast? We can talk about...
Dude, we can talk about anything.
Inflation. We can talk about...
all sorts of stuff. We got time.
Yeah, we've got plans.
I have not had any repeats on the show so far, except myself and St. Francis de Sales. So I think we're good. We have plenty of opportunities. If anybody's listened this long, like, thanks for listening, because this is quite late.
Sorry to anybody who's listening this long.
Yeah, right. Everybody, this is what people wanted to hear. Yeah, thanks for listening. We'll have to get this Dr. Kewl back on at some point. And maybe someday you can know his real name. It's just Kewl spelled with a K. It's surprising.
It's Kewl.
Kewl, that's right. Any last words, buddy?
Oh, jeez. I think know yourself, have self-insight. You're human. You're human to... knowing that you're human and you're prone to human errors, and that's okay. It's okay to have biases and mental pitfalls, and when you're under stress to make bad decisions or not be able to make good decisions. But if you are cognizant of that and you can mitigate that, you can be a better human.
Yeah, you be the best provider you can be. And that is not just within healthcare. Like, you provide for, I mean, we're both dads, husbands, like, you need to be the best provider you can be in all areas of life. So, and not only, you had mentioned earlier, just because you know that there are pitfalls, this can lead you to that false sense of security, thinking like, well, I know that I do these things, or I know that I'm fallible, but this isn't one of those times. The second you think that you got it figured out, you might be wrong. So always like approach things with a spirit of humility, and I think you'll be able to provide whatever is needed in that moment appropriately, and be diligent, be a good, decent human being. Those are all of our closing words. I think I've used them up. I could just ramble on forever, or we'd end up with a new topic. So catch Dr. Kewl next time. All right, man. Thanks for coming out.
Thanks for having me.
Yeah,
I had a really good time.
Yeah, I'm glad.
We could go on for hours, I feel like.
Yeah, we're 2:45 right now.
Jeez.
Yeah.
Sorry, you're going to have to edit this.
All right, people. Thanks for tuning in. This has been Vitals and Virtues, and we'll catch you on the next one. St. Francis de Sales, pray for us.